Hello and welcome back to our new online series of controversies in rectal cancer. This collection of video content will allow us to explore some of those difficult decisions that our multidisciplinary team members sometimes have to make for these patients. You'll be able to watch expert lectures on controversial topics, see our expert MDT panel discussing challenging cases, and enjoy some critical analysis and commentary. A common theme will run through the broadcast, and in this episode we'll be looking at the MDT in more detail. How the MDT members make their decisions and what impact this has on patient management. Are we all making the same decisions? Are they the right ones? First up is James Kinross, a senior lecturer from Imperial College in London, who's going to talk to us in more detail about this. I hope you enjoy watching.
Hello, my name is James Kinross. I'm a senior lecturer and colorectal surgeon from Imperial College, London, and today I've been asked to talk to you about the MDT, and I've been asked to answer two specific questions. How can the MDT improve patient outcomes, and are all MDTs making the same decisions? I suspect you probably know the answer to that question, but in the next 20 minutes or so we'll endeavour to do our best to answer those two questions. I have a few disclosures, none of which are particularly relevant to today's talk. So, just up front, the key message from the talk is really pretty simple, and the key take-home is that whatever your choice of surgical technique or approach to managing that patient, the MDT is still the gold standard, and that decision should still be made within the context of an MDT. And of course, you have to vary that to both the patient and the resource that you have available locally, and that's going to vary no matter where you are in the UK. Of course, the reason we have an MDT is because it's still the best way to make effective decisions for our patients, and we all collectively have the same goal, which is that we want to improve outcomes from patients with rectal cancer. And we know that those outcomes are variable across the country, and we know that we still have poor outcomes, particularly in stage 4 disease. So the goal of the MDT is of course, to improve outcomes. The problem is that when you place the treatment of rectal cancer within the broader context, that patient will have to navigate an increasingly complex journey with increasingly complex multimodal therapies. And you're treating a heterogeneous disease with an evolving suite of treatments available to the clinician and to the surgeon. So that MDT has to function across an entire patient journey, not just at the time of diagnosis when you're planning your operation. Now, as surgeons, we often think about the incisions that we're going to make, and we worry about that because we think that that's going to have the greatest impact on our patients' outcomes. But actually, it's the decisions that we make that are the key drivers. And probably the balance is well in favour of those decisions. So the MDT is designed to try and help us get the best out of our decision-making process. Now, this is my MDT. It's some of my MDT. It's slightly bigger than that, actually. Our MDT is an MDT within a tertiary referral centre, and we probably see around 40 patients that we discuss a week. But they're very complex because we run a peritoneal and a HIPEC service, and we do complex and locally recurrent disease, and we also have a shared MDT with St Mark's. And we only have 2 hours. It runs from 7:45 in the morning to around 10 o'clock sometimes, but usually 9:45. And that really gives us around 3 minutes a patient, which is not a lot of time. And we always have a power failure, 8:30 a.m. every week without fail, which shuts down our imaging system. And so we are having common problems to many of your MDTs out there, which is there's just not enough time, and we've got an increasing burden of disease that we have to discuss. So if you go right back to the beginning of MDTs, MDTs were designed to help us improve our decision-making by discussing those cases where there is uncertainty. It's designed to help reduce this principle of uncertainty. So you can think about an MDT as a brain trust. It's how we help answer complex questions by going to our colleagues and having a process of peer review. At least that's the theory. We have some very specific goals. And of course, these can be thought about as primary goals or secondary goals. And the primary goal really is, of course, high quality oncological decision making. And that doesn't just mean the outcome of that decision, it's the structure and process of how we make that decision. And it's how we communicate that decision to our colleagues, because as we deliver multimodal care with a multidisciplinary team, we have to ensure that the messaging from that treatment is consistent across them. And we have broader goals, which to really treat our patient within a holistic setting. We oncologically may know what we want to do as clinicians, but our patients might have very different ideas about what is right for them. And those views have to be represented and accounted for in the MDT. Our job is to educate. Our job is to ensure quality and to maintain that quality through audit and governance. And of course, it's to generate evidence for our practice through the adoption of our patients into our clinical trials. So if we look at what an MDT should be, it should have basic structure, a basic governance program, and it should be able to deliver those effective clinical decisions within a defined teamwork and team structure. And it should really also focus on professional development. And I just want to highlight here the importance of leadership. Having an effective leadership within the meeting itself and simply running it day to day, minute by minute, when you've got those precious 3 minutes per patient, but also strategic leadership and leading that peer review process of your MDT is incredibly important. And we'll break that down a little bit. Now, some of you may be aware that there is a World Cup going on at the moment, and there was probably one of the greatest upsets in World Cup history recently when the Japanese team beat the Irish guys, and it was just fantastic. It's just brilliant game to watch. And it kind of got me thinking about the importance of teamwork, okay, and why the Japanese were able to turn over the Irish, who were the #1 team in the world at the beginning of this World Cup. They're far, on paper, inferior team. And they did that really through perfect planning. They knew their home ground very well. They practiced for the conditions. They had unbelievably effective communication and brilliant leadership. If you look at the performance of Michael Leach when he came on 30 minutes into the game, he transformed it. And they knew what their mission was and they stuck to it. And they had to overcome significant adversity. And really, that's what we're doing in an MDT. Of course, if you're running an MDT in the NHS, the adversity we face is time, it's resource, it's complexity of disease, it's the technology that we have to use to run that MDT, and the volume of patients that we have to get through. But we are all pushing in the same direction, right? We are trying to improve the outcomes for our patients with rectal cancer. So when is a team a team? Well, actually, that is mandated for within the NHS, and we have very clear definitions as part of our peer review for managing patients, and also the type of outcomes that our MDT has to achieve to be considered a team. So your MDT should be doing at least 60 colorectal cancer resections within that MDT with curative intent per year. And the MDT structure needs to reflect the treatment of rectal cancer care. Specifically, you need an oncologist, for example, with radiotherapy experience. So in fact, you need 2 oncologists, 2 colorectal surgeons, a colonoscopist, that can be a surgical colonoscopist, and a histopathologist. The nurse specialist, I just can't highlight the importance of that and how much I value my colleagues where I work at Imperial College. But of note, there's 2 little things at the end there. You need someone who is nominated to provide information for patients, and you need someone who's nominated to represent the type of clinical trials you're going to do in your trial. The problem is the one person that isn't there that perhaps should be there is the patient. And we need to find ways to be absolutely sure that our patient is represented in our decision-making process. You will often find in MDTs that people will have very entrenched positions on what they believe is the best standard of care. You are not trying to solve a problem like Brexit. Your MDT should not take 3 years and leave your clinical team in a state of an existential clinical crisis. Your job is to effectively problem solve, but to reach a balanced decision between your peers about what you think is best for the patient, and then to document that. So does it work? Is it effective at treating cancer, particularly rectal cancer and its associated complexities? Well, we've got reasonable evidence that it does. They were first introduced MDTs in around 2003 with the work of Professor Mike Richards, and they were then mandated into clinical practice within NHS, and we've been able to study them within the UK and also abroad. So here's data from a single surgeon experience looking at longitudinal changes in survivorship over time in one centre. And what you can see in this data set is that over time, with the use of better decision-making, he increased or she increased the uptake of chemotherapy, and they were able to demonstrate improved survival in Duke C stages of cancer. So locally in single centres, it seems to work. We also have evidence that it improves operative mortality. So I open by saying that the key message of this talk is that it's the right operation for the right patient at the right time, and having your peers helping you have sometimes quite challenging discussions about the best operative practice is beneficial for your patients. So again, in this study now, published in 2013, in 811 patients with primary rectal cancer, this was in Holland, they were able to demonstrate that that the MDT changed the way that they imaged and planned their operations and improved their operative outcomes. But they did find more metachronous distant disease, and they didn't demonstrate a survival benefit, which is quite controversial because MDTs come with cost and time constraints. What about advanced disease? Well, this is data on liver metastasis, and this is also quite compelling. This is, again, not a trial, we have to remember that, it's retrospective data, and this is coming from Taipei. And this is looking at 3-year survival rates, which improved dramatically. And in fact, MDT on a multivariate analysis was an independent prognostic factor. It improved the number of patients they were actually able to operate on, but that did not really have a big impact on their lung resection rates. So it seems to work for advanced disease, but how does it change our practice? Well, this is Paris-Texas's data from the Marsden MDT. I've had the pleasure of sitting in that MDT as his registrar, and they always have good, robust debate with very considered decision-making about their patients. And this graph shows you two interesting features. On the left side, you'll see their referral rates going up quite considerably, and then the number of patients that we're operating on, and you can see that they were getting referred more and more patients between 2010 and 2014, but operating less and less. And that's because their selection criteria, as they learnt to manage these complex cancers, changed, and they became much more selective. And with that came a fall in the percentage of their R1 rates and the quality of the procedures that they did. So as you know, there's a difference between operative outcomes and oncological survival. And is this survival universal? Do we see it at other centres? Do we see it nationally? Well, we have really quite good evidence that that is indeed universal. And you can see in this trial survival curves which are consistent with the data that I've already shown you. But what they also show is that the survival benefit is not uniform across all disease types and all disease stages. So the greatest benefit seems to be in this cohort of patients that are presented here in this trial in patients with later disease. And there seemed to be, quote-unquote, little advantage in patients with early tumours. Now, I would say that's really quite controversial. And I would say with the advent of the SPECT programme that actually we need to challenge that. And the second thing I would say is that many of these retrospective studies seem to have a degree of selection bias. And you should think about that when accounting interpretation of the data. So if we think about early disease, one of the problems we've had in MDTs is that we seem to have an increasing burden of work to do, as nearly all decision-making is put back into an MDT process. And a good example of that is the management of early diseases. We've had a growing burden with the increased adoption of our endoscopy practice and cancer screening programs. And we have a real challenge of how to manage these early cancers. And so we now have a significant polyp and early colorectal cancer group that was formed out of the Pelican Centre. And they've toured the country trying to educate and train MDTs on how to better manage these patients. And so there's a fundamental question. In an already overburdened MDT system, do we have room to further discuss even more complex patients, or should we be taking this decision-making process elsewhere? Now, many of you will sit in MDTs that may be within a regional network, and there are various models for achieving this because increasingly you need subspecialist care to help deliver, or I should say subspecialist expertise to help deliver high-quality care. So some systems will move to a hub-and-spoke model, and again, there is good evidence that this works really quite effectively. So again, this is another Dutch study with 400 patients from 3 different hospitals referring in to a single centre of excellence. And what they found there was that the performance of their radiology effectively increased, and the number of patients that were being discussed increased, and they found a reduction in the time between the first tumour biopsy and the MDT meeting. So they improved their process by having a more effective network, and there was more clarity about exactly what was happening and that they were complying with their guidelines at a more effective rate. And this brings me on to my next component of the talk. So if they're so great, these MDTs, why are we struggling to meet demand. Surely they must be working perfectly. Well, they're not, and they're not working perfectly because we are under-resourced, and there's good evidence for that. So this is the Achieving World-Class Cancer Outcomes document that was published in 2015. And if you read that document, it's interesting because they state, MDTs are under growing pressure from increased demand and insufficient support, and they're not operating as effectively as they could. And I certainly feel that in my MDT. I feel like we are overburdened. There's almost too much to discuss, certainly within a 2-hour time frame. And they made several recommendations, including the application of streamlining, the development of protocols, the importance of auditing, and the importance of MDTs to consider appropriate pathways of care. So why did they make that statement? Well, this was some data that came out of the CR UK, and they produced a report in 2016 looking at meeting patients' demands from MDTs. And they basically went and looked and interviewed about 2,000 people that sit in MDTs, and then did focus questionnaires, and they went and observed some MDTs. And what you can see is a massive growth in MDT activity since 2011, but that's not reflected in the growth of staff that actually have to support and manage these meetings. And you can also see the total cost is increasing as we do more and more work. So it cost us nationally about £88 million in 2011 to 159 million in 2014. It's worth noting that the sort of burden of patients with cancer at the moment in the UK is around 300,000 patients a year. I shouldn't refer to them as a burden, of course they're not, but the amount of disease we have to treat is quite significant, and that's going to grow significantly to, we predict, over 500,000 a year by 2030. So what are the factors that also create confusion? Well, the MDT is quite large. It usually has about 14 people then managing it. And the average discussion, according to some previous observational studies, is 4 minutes, but that's quite variable. And the CR UK report was actually 2 minutes. And you can see on that graph compliance, so how often do we hit the guidelines that we're supposed to, and what we think is the importance, so subjectively what we think is important that we should be doing. And what you can see is that they don't map onto each other. So we're quite good at getting compliance, about getting a clear agenda, getting the right results there, and having a clear owner of that data set. So we think it's important, we're not bad at delivering it, but we're not so good at getting enough time, so our time management is poor. We don't necessarily review the right decisions, we don't prioritise complex cases, and we don't properly risk stratify our patients. And that's sort of general, I think, a general consensus from across the board. So there's been a bit of pushback. Do we really need to be discussing all simple cases in our MDT? Well, this retrospective review was published in DCR in 2014, and they looked at 261 discussions over 197 patients. And they made the observations that actually they only really changed the decision-making from the beginning of that MDT in under 4% of cases. That's quite a small percentage of cases. And those decisions were most effective when you looked at surgical planning and radiological review. But I think since then, the remit of the MDT has broadened further. And I would also show you this data. So this is data from EMBOCAP. And what this shows you is variation nationally in MDTs according to the recommendations for radiotherapy use. And there's a couple of interesting things about this graph. The first is that everything in dark grey that you can see there is missing data. So it means that our MDT is failing one of its core functions, which is to record the treatment outcomes from those interventions. And the second thing you can see is in blue is the application of long-course chemoradiotherapy. And you see really marked variation across the board. Okay, so rates range from 24% to 61%. That has to mean that we're not making uniform decisions in the way that we treat our patients. And it has to mean that there's significant variation in the way we treat rectal cancer. And that's true in surgery. So across that, probably 53% of patients underwent major resection according to the EMBOCAP data set, only 7% had local excision. If we think about early cancer, as was just mentioned with the SPECT protocol, maybe we need to change that figure. This is more granular data. So actually the EMBOCAP data goes a little bit deeper. It looks to report on the number of cases that we report according to the peer review criteria. And basically everything in green means you're meeting that criteria, and if it's red, you're not meeting it. And you can see wide variation across the board there. And I have deep sympathy for for hospitals that are not meeting it. I promise you it's not because they're not working hard enough. Everybody is flat out and working hard enough. They're just overburdened and under-resourced. So there is variation, and there have been a number of different studies trying to understand why that variation exists. And it seems that there is variation between patients with colon cancer and patients with rectal cancer. They're a different discussion. And patients with colon cancer, because they're slightly less complex, they tend to be discussed less deeply and in less detail than rectal cancer. And part of that is because of human behaviour. So if you look at human behaviour, quite often we know what the protocol is, but we deviate from it because of our own inherent biases and experiences. And in fact, when you map that using machine learning, this is actually from a breast cancer study where they compared what was actually discussed in the MDT with what was best practice guidelines according to ESMO or the NCCN guidelines. That actually is quite a lot of variation, and the machine can identify and predict it. And the reason that they can predict it is because we change behaviour in a predictable way because we have inherent biases. I think it's worth noting that the law has recently changed on consent, and that there is a legal component. So the advice that we give as an MDT is going to reflect the decisions that are made in patient care, and we have to be cognizant of that when we record our outputs from these MDT sessions. The way that we phrase our recommendations needs to be balanced, and it needs to be sympathetic to the patient, to the surgeon or clinician that's actually got to apply that advice in practice. And I'm sure we're all aware of the new Montgomery test, which actually has changed the legal basis for the way that we consent, and that patients now need to be reasonably aware of what they would likely attach significance to in terms of their treatment. So, for example, organ preservation. So the MDT, therefore, has to be aware of that. So the problems with MDTs are that they may increase the length of time to treatment. They don't always advocate by national guidelines. There is variance. We're not applying them actually internationally either, and therefore it's difficult to measure your performance because you're not standardizing your treatment and the patient is not present. There's also technical problems. It's time consuming, and we sometimes bias our decisions towards riskier treatments, and treatment decisions differ, particularly depending on patient phenotype, so older patients, single organ metastases. So we have some guidance to change things. So again, if we come back to the CRUK statement, they've made 6 recommendations that will help us change the quality of our MDTs in the way that we structure our MDTs. And I've listed them there for you, I won't read them. The important part is that we think more about protocolizing and measuring the quality of our MDTs to take a lot of the burden of the decision making out. We should be able to put some of our simpler cases into a process that means that we don't really need to discuss every single last case. But we also need more practical solutions. So here's a picture of a cloud, and I put that picture of a cloud to remind me to tell you about cloud computing. Invariably, technology is important. It will have to play a role somewhere. So there are a number of different authors that have looked at trying to validate what a virtual MDT is. A virtual MDT doesn't simply mean having telemedicine or the report for the capacity for remote dial-in. It means a fully virtual MDT. So that means the entire process does not require 14 people to sit in a room for 2 hours to make decisions. And we do have these decisions. So Nottingham University is currently trialling the Involve system, and the Macmillan virtual MDT system is now being trialled up at the Christie. So we need to see how these things work in practice to see if we can take off some of the burden from the MDT. So in summary, the MDT is still the gold standard for decision making in cancer care, and it will remain so. The MDT doesn't need to go, it needs to evolve, and we need to make it more efficient and more effective so that we can adapt to the changing burden of disease and the time constraints that we have. It should aim to provide best evidence, and it should really aim to make sure that we audit the performance of our MDT and recruit patients into effective clinical trials. But it does require leadership. These things cannot be delivered without leadership and without proper engagement. And when you get that right, you can beat anyone in the world, and you can certainly beat rectal cancer. So on that note, I'm going to finish there and remind you that we are evolving through collaboration. This cannot happen individually. It takes a team to run MDT. To run an MDT, it takes a team to help push it through to its next iteration. My name is James Kinross. It's been a pleasure to talk to you, and I look forward to seeing you in the virtual world online for a future discussion about rectal cancer care. Thank you.
What a fantastic lecture that was. And we'll be discussing that in more detail later on in the programme. But for now, let's look at one of our complex MDT cases that was discussed earlier in the day. Hello and welcome to the ICENI Centre's Rectal Cancer Multidisciplinary Team meeting. My name is Greg Wynn. I'm one of the consultant colorectal surgeons here in Colchester in the UK, and I'm delighted to be able to invite here today an expert panel from around the country to discuss these difficult cases. Before we start, I'd like to get them to introduce themselves to you.
My name is Tan ARULAMPALAM. I'm a colorectal surgeon at Colchester Hospital.
Hello, I'm Ian Daniels. I'm a consultant colorectal surgeon at the Royal Devon and Exeter Hospital.
Jim Khan, consultant colorectal surgeon, Queen Alexandra Hospital, Portsmouth.
James Kinross, consultant colorectal surgeon and senior lecturer at Imperial College in London.
Anna Wordley, clinical nurse specialist in colorectal care at Colchester.
Alex Stewart, clinical oncologist in Guildford, with a particular interest in brachytherapy.
My name is HUGO Ford. I'm a medical oncologist from Addenbrookes Hospital in Cambridge.
My name is NAJIB HABOUBI. I'm professor of GI pathology in Manchester, UK.
This is a 55-year-old lady with a BMI of 23. She's very fit and active. She's got no past medical history, on no medication, and she is presented with isolated fresh rectal bleeding. Examination reveals a sessile polyp at the anorectal junction on the left side, and it's just about palpable. It's just some thickening you can feel. Endoscopy confirms a very low tumour. It's about 40 millimetres in diameter, and the biopsies are high-grade dysplasia. There's also a sigmoid polyp of about 10 millimetres, subpedunculated, that's not removed. This is the low rectal tumour. So you can see how low it is there. At the bottom right-hand side is the anal canal. We've got some staging to look at, Darren.
So in keeping with the endoscopic pictures, you can see this fleshy additional soft tissue right down at the anorectal junction, as far as the proximal anal canal. But the muscularis propria returns a normal signal all the way around. In fact, there's also preservation of the normal sort of mural stratification and stripy appearance. So we would consider this very superficial, probably an SM1 or SM2 lesion, nothing to suspect this has progressed to SM3 or T2. There are no other adverse features. There's no lymphadenopathy, no EMVI, just a fairly superficial but fleshy 2 centimetre polyp.
How far is it from the muscularis propria? I mean, you said one SM1 or 2.
It looks like 2 millimetres, almost.
2 millimetres.
Yeah.
Okay, Ian.
So the patients had a colonoscopy. It wasn't just a flexible sigmoidoscopy.
It was a colonoscopy.
Okay.
They left a significantly sized polyp in the sigmoid colon, and they biopsied the rectal tumour. It's high-grade dysplasia.
So we've only got high-grade dysplasia at the moment, and given that there's still a polyp in the sigmoid colon, I'd quite like that excluded from the process, and I'd quite like some further biopsies on the rectum to know exactly what we're dealing with in both sites.
Okay, sounds reasonable. So she was rescoped, flexible sigmoidoscopy, a sigmoid polypectomy, but the rectal tumour wasn't re-biopsied. Sigmoid polyp.
Right. Did you want biopsies or
Yeah.
the big biopsy? Because
Just the original biopsies.
Sigmoid polyp.
Yes. No, well, I think the biopsy shows actually that it is tumor, it is cancer.
I think we might be talking about cross
The
purposes.
sigmoid polyp.
The sigmoid polyp.
was benign.
Let me just the sigmoid polyp. You know, I'm supposed to be coming prepared, right? Where is the sigmoid
That's real
polyp?
life.
It's a normal MDT.
Except I haven't seen the slides.
So if you don't have the sigmoid polyp, I tell you it's benign and fully excised.
I can't
despite
see.
its
I
size.
can't see it. I can't see it.
The reason
It's
why
not
the,
included in my report.
Thank you. The reason why the rectal polyp wasn't re-biopsied, I think the conversation had already been had on the basis of the MRI that she was erring towards a TEMS.
Okay.
And so she'd already been offered a TEMS, I think.
And had we offered her an endorectal ultrasound scan?
No. So
Which is actually
explain what extra information that might give us.
Yeah.
Well, for those of us in rural or MDTs, we find it incredibly difficult to break down very early stage lesions on MRI scan. Particularly, well, in most areas of the rectum, but particularly low down as well, where the distances between mesorectum and the relationship to the anal sphincters, etc., and the different muscle layers. So, given that if you're able to look at things from a number of different angles, you may get a clearer picture. And an endorectal ultrasound scan would allow us to look at the layers of the bowel wall and whether this is a purely mucosal lesion or whether this is deeper invasion.
But I mean, do you interpret that yourself, or do you do it yourself, or you have some people do?
So personally, I'm not a TEMS surgeon. We have a TEMS team,
Right.
and the TEMS team would do that themselves because one of our big fears is that somebody has a TEMS for a big cancer.
And I think that's a real problem with MRI and the surprise cancer and the surprise T3 cancer when actually it's not being called accurately. So I think multimodal imaging.
You're probably likely to overstage it with the MRI at that level. We find that the accuracy of MRI, especially in differentiating between T1 and T2, it loses a little bit in the lowermost rectum. And I think having an endorectal ultrasound is quite complementary to get that, especially if you're looking into SM1, SM2 differentiation. So we routinely would do that. But again, it's the availability of a resource and then some training. It's not that hard to train, and I think any surgeon who does TEMS or local excision should be able to learn that fairly swiftly too.
But that's where if you're going to offer local excision, you've got to offer the whole package.
So we haven't got evidence of invasion. Jim, just take us through
No,
what's
there
going...
is. He said actually T1, T2. Sorry, SM1, SM2.
There's no pathological evidence
No,
of
no.
invasion.
No.
It's a benign biopsy.
I trust my radiologist significantly.
Well, I was very fortunate here because it's a high-resolution scan that happens probably more by chance than design to be perfectly tangential to the tumour epicenter. That doesn't happen all the time, and in fact I wouldn't say it happens over half the time, and I can be reasonably confident on this one because I can see that nice stripy submucosa and definitely a clear muscularis propria, but I would absolutely agree with everything that's been said that from a radiologist point of view, we do overstage these about 3 or 4 times more than we understage them because we sit there very nervous that we're going to understage it and you're going to get the surprise T3 lesion that makes us all very, very uncomfortable. We'd probably rather overstage than understage in every circumstance. So here, yes, with hindsight, I can be very confident about it, but in everyday clinical practice, yeah, there's every possibility I could say there's a little bit of T2 signal hyperintensity in the muscularis propria, let's call it a T2, and it's right down on the anorectal verge, so treatment's completely different then, presumably.
So Jim, I'm going to ask you about the anatomical location of polyps in the rectum and how that impacts on your management in this situation where you've got a benign biopsy and you want to find out what this is.
Yeah, obviously you need more tissue to be absolutely sure of what it is. And then the best end of the spectrum is going to be an early sort of high-grade dysplastic polyp which hasn't turned into cancer, or there could be a focus of cancer. I think repeating biopsies is not going to give you the answer. So one option would be to consider a full excision as a big biopsy of this lesion, and you can use TEMS or TEMIS for that. And TEMS is obviously the old technology with the Richard Wolf kit where you have articulated instruments and you can perform surgery in different quadrants of the rectum. TEMIS is a bit more flexible platform, and most laparoscopic surgeons who do single port surgery will be familiar with it. So you can use either or, but the basic principle is that you're going to excise a lesion en bloc so that the pathologist has the best chance to assess the margins of the lesion and relationship of that cancer to the walls of the rectum. Now, the question you asked was that based on the anatomical location of this, how would you best proceed to do that? And I think we know that in the extraperitoneal rectum, you have the mesorectal cushion at the back and laterally where you can perform a full thickness excision without getting any significant side effects or complications, then you can get away with it. But anteriorly or in the upper rectum, you have to factor in the possibility of a full thickness perforation with entry into the peritoneal cavity, which is not a major disaster as long as you know how to deal with it if that's going to happen. But I think more importantly, for any surgeon who's trying to do a full thickness excision of the low rectal cancer, you have to think ahead as to what the impact of that would be if you're going to coming back to perform a salvage resection, provided this turns out to be a T2 cancer, for example. So for a very low rectal cancer, anteriorly, for example, I'll be more worried about doing a full thickness resection, where if it turns out as a T2 cancer and you're going to be going back in, especially if it's a woman, you're going to find that that plane between the vagina and the rectum is going to be plastered, and you'll be forced to do kind of an unblock posterior vaginal wall resection with it. And that will make your operation more complicated, risk of more complications and delayed recovery as well. Similarly, at the back and laterally as well, the puborectalis sling is not going to be too far away. And if you do a full thickness resection, the bed of your resection end is going to be formed by levator muscles or puborectalis, which if it is a T2 or T3 cancer, you basically have got an uncontrolled situation. And the only option for you at that time to go back would be an APER, which could have been avoided by an ultra-low anterior resection, would you have known that this is a T2 tumor. So in summary, I would probably do a partial thickness resection, but a single piece, send it to histology and find out if it's a cancer or not, and if it is, what stage.
Just to add to that, the whole mesorectum just becomes fibrotic. It's very, very difficult, isn't it, to go back in.
The salvage surgery after a bad TEMS histology is not easy task. It is complicated. It is difficult. There are no planes, even in the straightforward cases. We had a patient referred, and again, the other option which we have not discussed here is the option of an ESD of this lesion, and it is close to the anal margin. Yes, it might be a bit sensitive for the patient, but in centers where they offer ESD, you can do that. And I had to operate on a patient very recently where my gastroenterology colleague has performed an ESD for an anteriorly based tumor. He ended up going full thickness at one place, and they put a couple of clips on to control it, and they were out, and the patient was absolutely fine, went home on day 2, had a histology which showed a T2 cancer in that specimen. She's 55, came back to my clinic. I had to do an anterior resection, and I was surprised at how bad it was anteriorly when we went in, and the vaginal wall and the rectum were plastered completely. It was a very difficult procedure at that stage.
Just on that point, if gastroenterologists do things in the rectum and put clips on, and you have a surprise finding of a cancer, the subsequent MRI and the signal void is a nightmare. So these patients have to be managed really carefully right from the get-go.
Especially if there is no preoperative MRI, because often the gastro will catch on and perform an EMR or ESD on these lesions without a baseline MRI. And we have published in this as well that anything which is more than 3 centimeters in size in the rectum, when they have type 4 or stroke 5 pit pattern, you should have a baseline MRI or at least a discussion in the colorectal MDT before taking on ESD or EMR on these patients.
Jim, I just, when your gastroenterologist actually like actually to polypectomize lesions, I mean, do they not follow the pattern in which that if this malignant? I mean, they're supposed to be. They are so good at this pattern business, the Paris patterns, etc. It's so good.
They're not so good. I disagree.
Okay.
I think they're very, very
No,
good.
I said. They tell me apparently that they are good. Now you're telling me they are.
Well, we've
not.
just meta-analysed the data and the value of optical biopsy on,
Thank you.
and actually what we find is they're very, very good in experts who do a lot of it all of the time. It's very reproducible, but in gastroenterologists that don't do a lot of it, because it's basically a qualitative analysis.
Yes.
There's variation.
Very subjective.
Right.
So,
okay, thank you.
they typically, they're like surgeons in many respects. They think they're much better at it than they actually are.
So endoscopy is growing at a rate of 12% a year. So somebody with a rectal polyp goes in for a Saturday or Sunday endoscopy, and somebody sees something, and the temptation is to nip it off. And this is the point. If it's about 3 centimeters, you should just stop, because there's no rush. You just need to get the MRI for all the reasons we've said.
Well, we had a position statement from the ACGBI saying that, can you do it? Can you do it on your own? Can you do it in one sitting? If you cannot, then refer it to somebody who can do it.
But most of the time, those specimens that you get will be a pile of ash, because that's, the truth is they come out piecemeal, and you can't orientate, you can't do anything?
Yeah, no.
So we have a polyp MDT now, and if you see a big polyp, the instructions don't touch it. You refer it to the MDT, you get an MRI scan, and then you have a consultant come back who reassesses it and then proceeds plus or minus.
So it's a real big takeaway point from this.
How big is big, James?
So the answer is, I think the question you're asking is what size correlates with risk of carcinoma in situ or risk of nodal invasion. So big is more than 4 centimetres, I would count as really large. But when you get over 1 centimetre, your risk of malignant invasion starts to climb quite considerably. So for me, over 1 centimetre, that starts to send alarm bells, really.
So if you were writing a protocol for the gastroenterologist, you'd say anything over 1 centimetre, you want them to leave it alone.
Yeah.
So what, they've had an MRI?
Yeah.
Biopsies an MRI?
I wouldn't tell them to biopsy it. I'd say don't biopsy it. Because that might compromise our ability to come back and do a proper EMR or ESD. So I'd say don't biopsy it. If it's over 1 centimetre, it's got specific features according to, as Jim says, the pit pattern or its macroscopic morphology. Leave it. Just don't touch it. We'll send it to the polyp MDT. We'll inspect the images with a consultant gastroenterologist, get an MRI, and then reassess.
Good. I think one of the difficulties though is that how often are we presented with an incidental finding of a tumour in a polyp, and then the patient has been sent for the MRI scan afterwards, to which the request always comes back, well, where was it? Because your MR staging is entirely dependent upon
the position,
knowing the position so that you can go tangentially and perpendicular to the tumour.
So there's a big case to just stop, full stop. And I would probably support that, because we've certainly had cases where small polyps have been bisected, we don't know where it is, and then you're having a conversation with the patient without really knowing where the starting point is. And you can't even formulate a follow-up protocol that's based on any evidence then. So we would say stop.
And sometimes these patients pitch up in your clinic 3 months after the index procedure, when it's even very hard to find where the scar was. There's no real documentation. The distance measured by the endoscopist could be very variable, so you have really no clue as to whether it needs a full TME or a partial TME or going to be an ultra-low joint.
Okay, so in this case, the patient has had submucosal or intramuscular TEMS, probably a submucosal TEMS.
Is it intramuscular? Because actually there was no reference to the muscularis propria in the biopsy. And then they gave us a Kikuchi. And my views about this, and indeed the views which is shared by all the pathologists, unless you have the muscularis propria, you cannot actually give a Kikuchi staging or grading. But I don't know that actually there's no mention of the muscularis propria. So that's from one thing. But quite correctly, actually, you mentioned actually the depth of the invasion, which is 1 millimeters. That does not, the depth in millimeters does not equate to Kikuchi at all, because Kikuchi doesn't talk about millimeters. It's about 1/3.
So this is a cancer, Najib, is it?
Oh, you mean I didn't tell you that? No, it's a cancer. Of course it is cancer.
This is a cancer. It's a T1 cancer.
We have a radiologist who says it's cancer.
It's SM1.
And it is, so this is SM1. But actually, the lateral section margins were free. The deeper section margins is less than 1 millimeter. So it's 0.7 millimeters. And according to the dogma, that it is incompletely excised, or it is actually reached the section margin. It's less than 1 millimeter.
Okay. Any other features you want to know about this polyp?
So this patient, I think, would have been good for the PRESERVE trial when it eventually opens. And the reason I bring that up is that they've tried to reach out to find a consensus for risk, for defining how you should play out your clinical strategy for these people. So I think the ACP have a document on this, which they've defined features, and then the PRESERVE trial have one as well. But effectively, you're looking for depth of invasion, you're looking for features of extramural vascular invasion, you're looking for size, and of course, you're looking for LVI as well.
And tumour budding.
And tumour budding. Well, tumour budding is in the ACP. Yeah. So you can then risk score based on those features. And the ACP statement and the PRESERVE trial has a different score which you can plug those data into, and they will rate you as low, medium, or high risk.
Okay. any other adverse pathological features?
Not in this particular patient.
So no other
But
adverse...
as been said, actually, that if you have poorly differentiated, which is not mucus secreted, which is not, apart from the depth of invasion, it is actually less than 1 millimeter. The rest are, I mean, that is the bad prognosis sign, which means actually there's a high percentage of recurrence, a high risk of recurrence.
Okay, 0.7 millimeters.
Yes.
In an SM1 cancer.
I don't know this
Where's
is
the data
SM1.
that
I don't know
there is
that this is
a high-
SM1. It is stated SM1, but as I said, unless we see the muscularis propria, we cannot SM them. We cannot.
Okay. But it's been measured at 1,000 microns.
Yes,
Yeah.
correct.
Okay. So,
So-
does anyone know the data for 0.7 millimeter deep margins in an SM1 cancer?
A 0.7 millimeter deep margin.
Yeah.
So I think there are different criteria that define margin. So for most people it's less than 1 millimetre, but I think certainly for the PRESERVE trial it's 0 millimetre, so it's at the margin. So they've changed the status. And I think it's always a bit of a heart sink. I mean, I've certainly done some TAMIS cases where you get a 0.8 millimetre and you think, oh, am I really going to treat this as an R1 resection? So I typically now use the PRESERVE criteria, which is tumour at the border histologically.
Sorry, which criteria is this are you using now?
PRESERVE.
Right. That has not percolated to the pathologist yet.
Well, you know, I think again, if you look across the literature, it's quite variable.
I'm sure,
Yeah.
but it has not actually, not in the minimum data set of the resection, of the local resection.
So James, this lady wants to know what her risk of local recurrence is without any further treatment.
So I think all of us, well certainly I am haunted by patients that were supposed to be low recurrence and seem to defy logic. So again, it comes down to the point about risk, how you present that risk to that patient in that discussion and what the patient's wishes are. We could calculate a risk based on the fact she's got quite a large polyp with, you said, she's not got any other adverse features at all. How big was the polyp?
4
So it's 4 centimetres.
Yeah.
So it's a big polyp.
4.5 centimetres.
4.5 centimetres with a 0.7 millimetre margin and no other adverse features.
No.
So I'd probably say, looking at that, her risk is going to be somewhere between. Well, Chris Cunningham will always say, whatever data score you look at, it's always 20%. So you know, her risk is going to be somewhere between 10 and 20%.
Which would fit actually with the position statement, that pyramidal system which we have put on of the risk factors.
With
that,
the ACP.
yeah.
Okay.
So what are you going to do?
Well, she's got 3 options. She's either going to watch and wait, and we're going to put her into a protocol and closely observe her, or she's going to have some radiotherapy, or she's going to go and have a TME. And frankly, I don't think we have good data to support any of those things, which is why we have lots of competing trials at the moment trying to answer that question. And actually, for me, trying to discuss this in our MDT is usually worse than Brexit, because basically people have very entrenched positions on what they should do. And either you're radical and you should just have a TME, this is a young patient and they need curative treatment, or you're
preserve the organ.
You're trying to preserve the organ, and you're in the organ preservation camp, and actually that should come first. And I think coming back to the discussion we've had earlier about organ preservation, how you phrase this to the patient is absolutely critical. Because if you go in with your bias on the table, it's very easy to talk a patient into the outcome that you wish for.
I may be a bit controversial here, but I mean, you know, breast surgeons have practiced this for longer than we have with wide local excision for breast lesions. And if they get a positive or closed margin, they're happy to go back in and shape the cavity to see exactly was it a true margin or is the risk really there as bad as you think it is. And in my practice, I've done that in selected patients where the patient was very keen not to consider any other option of going for radical surgery or radiotherapy, and they just wanted to be surveyed or monitored, and we will follow them like a TAMS protocol or track trial protocol with 3 monthly scans and reviews. But we have gone back in and tried to take a full layer muscular resection of that area as well to see if there was any invasive cells in that margin, to help you decide whether you go for a TME at this stage or you can carry on with that. But again, as I say, there's no hardcore scientific data behind it. It's just a practice that you could do if you want to have a patient in that group.
So I think you're right that those are the 3 options, James. And I think the critical thing is to have a completely, one has to be as open-minded as possible. And I think when you're talking to the patient, you have to have that other support of the nurse specialist, and you've probably got to say, we're not going to make the decision on this appointment unless they say, I want it out. And I think that's a really important, I don't know what you feel, Anna, because this is a really difficult...
No, absolutely. I think it is absolutely paramount that these patients have time to consider, you know, all the things that you've told them. You know, they'll often come along with something to record what you're talking about. And having it all detailed in a letter can be really helpful to talk, you know, to think, to talk to their family and make a really informed decision.
And I'm going to ask you that, throw the scenario out there, that we're talking about a TME, so I presume we're talking about restoring her bowel continuity. We're effectively giving her a very low anterior section, very, very low anterior section. She's 45. I don't know whether she's had children, whether she's had traumatic childbirth.
55.
Yeah.
Traumatic childbirth, what her pelvic floor function is like. And we're potentially offering her an operation with an interim ileostomy to put her back together. And with all the data on LARS, or low anterior section syndrome now, are we biased towards the fact we wish to avoid a colostomy in her from the moment we go in, or do you think that's her perception that?
Again, I think it has to be put to her, you know, as, you know, one of the choices, really, because I think unless you really understand from the person what's really important to them, we can put our bias on, you know, what we think should be the outcome. And the thing is, with these patients with the very low, or, you know, coloanal or low anterior resections, it's very difficult to predict those that are going to continue to have problems. You know, some who you expect to struggle seem to skip over it quite well, and others who you don't expect it, you know, then really struggle on, and, you know, take a lot of support and guidance in trying to sort of manage all of that. And that would be my feeling on that.
I think because of the Montgomery ruling, we're now obliged to tell patients of their treatment options, and to do that in a balanced way. And I have to say, my MDT now, I find it so difficult that actually I find the only way that we can really do this is within the context of a trial, because actually you have all the patient support information there, and you can do that in a way where you say to the patient, look, we don't know what the answer is. And sometimes that's the hardest bit, saying we just don't know what the answer is, and you can help us with this. Some patients will have a very clear view of what they want. They will rather literally die than have a colostomy. And others will be just completely frightened and terrified about the treatment and won't know what to do.
So I'm going to just, with a slight different hat on, say, is that a problem of patient education, that there is such a fear over a colostomy that those fears may be unfounded compared to what the data that we've got on low anterior section syndrome?
I think you're absolutely right. And I think again, there are a group of surgeons out there that will say, look, you're 55, don't die of cancer. Let's just cut this out and you will never have to die of cancer. Your disease is completely curable. And just, we can teach you about a colostomy, it'll be okay. But we're not the ones that have to go home with the colostomy bag.
No, and I think it's you know, each patient presents themselves as unique, don't they? They all come along with their preconceived ideas. A lot of them will have prior experience of other people with stomas, and they come along with all of this already boxed up, and it can be really very difficult to pick that apart.
So I think this is going to be an increasing problem with an expansion of the consultant body. So lots of young surgeons coming into the service, and an increasingly ageing population. And Ian's point is very important, because the rate, you know, the metrics that we're all measured on, you know, the proportion of colostomies, APRs, etc., is going to change. And that may not actually be an adverse thing. And the context is really, you know, for the ACP, we probably have to take that into account.
But this is going to change for more fundamental reasons, which is that the long-term plan for the NHS is to increase the number of early cancers that we detect. We're doing more endoscopy, and 70% of our tumours are all early now. And we're going to have a massive growing burden of disease. We're going to see more and more of these, not less and less. So we need a strategy as a group of professionals as to what we're going to do. And actually, that's why I think these trials now are so important. The trigger strategy, the preserve strategy, the TZAR strategy, they're all slightly different, and you've got to pick your horse to a degree. But that's why I feel quite strongly that these patients need to be offered a trial, Because we collectively, as a group of professionals, have to be able to give patients now information which is more robust.
So it's very interesting because breast surgery, prostate cancer management, is way ahead of us. We've just not taken those steps. Perhaps the last 10 years we've gone some way towards it.
But we know that patients do better in trials. So there is an encouragement for patients to take part in trials. But let's not forget that we need to look at core outcomes and patient-related outcomes here. We're not necessarily just going on hard surgical, oncological endpoints. What really matters for the patient is what's going to happen to them in 5 years' time. What is my stoma, my bowel function, etc., going to be like way after you've forgotten about me?
But that's what makes these trials so hard to recruit into, because patients often have quite fixed ideas.
Okay, I'm just going to interject there so we don't go into the next case and the subjects offered in that case. But I just want to, you mentioned a local recurrence rate of 10 to 15%.
Local recurrence? 10%.
She's opted for surveillance only with no adjuvant therapy at all. I just want to come to Alex and say, if she had some adjuvant radiotherapy here,
so because we're a contact brachytherapy centre, we would offer contact brachytherapy. Her risk is predominantly the local risk because of that close margin. So if the margin had been 1 millimetre or more, we wouldn't have offered anything. I would offer 2 fractions of contact brachytherapy. Benefit of that is that you should keep the more systemic effects of radiotherapy to an absolute minimum, and the surgery should not be particularly more difficult because it's so superficial if she did require salvage surgery. The surveillance, I think, is really important because sometimes people don't surveil these very intensively. But if we've had a patient that we've given Papillon to, or a patient within the TREC trial, we're doing these 3-month MRIs and sigmoidoscopies, and I think we need to make sure we've got that.
We'll come to that in a minute. What reduction in the risk of local recurrence are you going to tell the patient after your therapy? That's the question.
I think it's really difficult to know because all we can say is we think it will reduce the risk of recurrence.
There's no data on that.
But there is no data on it at all.
You can't quote any evidence.
But we are recording them all within the database at the moment, so that is something that we should be able to have an idea of our recurrence rate nationally relatively soon.
Okay, and finally, I just want some ideas about how this lady should be followed up now.
Carefully.
I was going to say exactly the same word. Okay, carefully.
So
MRIs?
And scope.
We call it triple modality because it's the finger, the scope, and the MRI. And we tend to do the MRI before the sigmoidoscopy, so that in the MRI, my radiologist will say, just look at that area anteriorly. That could be a little fold, or that could be this. And so she'll identify areas that she's a little bit more suspicious of on the MRI. And then that helps the endoscopist to see precisely where they might be looking.
Okay, give me an idea about frequency.
So we're going every 3 months, and we've got 2 endoscopists that are doing all of these patients. So they're consistently seen by the same 1 or 2 people.
For the first year, and then ease off a bit, or we carry on after?
Depends how your nerve holds. So we've been doing watch and wait now for 15 years following chemoradiotherapy, and to begin with we were doing 3 monthly scopes for 2 years. But as the time has progressed and we've become more comfortable with that, we're doing it for a year and then easing off. But the question also is, how long do you follow these people up for? So I think, we may not be seeing a problem a year, 2 years down the line, but if there is any remaining cells there, they may present at a later date. Indeed, the cases reported at 7, 8, 9 and 10 years.
Particularly after radiotherapy.
Yeah.
And this lady, you might get a recurrence a little bit earlier, perhaps. But,
Post-Papillon, the recurrences tend to be around the 16 to 18-month stage, so we tend to make the more intensive follow-up for the first 2 years.
Yeah. Okay. It's a good case. So we've got a post-TEMS MRI and a 6-month post-TEMS MRI. Darren, is there anything really to say about those or not?
Only how difficult they are to interpret. This was a sort of submucosal well, that projects, but a submucosal excision, wasn't it? And all you can really see is a sort of pencil-thin, subtle, reduced, despite how large that flat tumour was, flat polyp, that's all you're seeing is a few grey scales darker. Then we've got a normal submucosal plane, and then the muscularis propria is right up against all the other sort of anterolateral structures here, so it would be extremely difficult to see if there's any extra mural disease in and amongst here. But you know, this looks good and clear, but you know, in isolation, these MRs are not terribly helpful. It's the change between this one and the next one, and clearly from us, in the same way as you may want the same person doing the scope, it would be very useful if you've got the same person interpreting, using exactly the same tissue planes and angles and imaging protocol. That's the only way that you're going to detect early recurrence before it becomes too late, and you're going to have to perform a very, you know, a much more advanced, extensive operation at the point where we're likely to start seeing intermediate signal outside of the wall here.
Okay, so that's what it looks like at 6 months. There's no endoluminal evidence of recurrence, and we've got to 16 months post-op now, so you've got a chance to compare your scans.
Yeah, it's identical, and again, that's reassuring. So there's nothing more to find, and you know, looking outside, further up the mesorectum, no nodes, no MVI, nothing adverse, but yeah, having two comparable scans is very useful.
Perfect. Okay, that's a good case. The key learning points for this case are that quantifying risk of recurrence after local excision is important for informed consent and joint decision making, and have a follow-up protocol in place for local excision of early rectal cancer, either directly or after neoadjuvant therapy. So welcome back to the ICENI Centre, where I've got my colleague Professor Tan ARULAMPALAM with me to discuss the lecture in the MDT case we've just seen. Tan, it was a great lecture by James Kinross. He's always full of enthusiasm and he presents great data. I always enjoy listening to him speak. He spoke about the functioning of the MDT. It's quite difficult sometimes to get a handle on how well MDTs work. There's no real measurements for that. The decisions we take in MDTs are quite intangible sometimes, aren't they, in terms of their outcomes. Very difficult to measure, and I think James did highlight that quite nicely. What were your thinking?
Well, I can tell you one thing for nothing is that all MDTs are flooded with more work. So the MDT in each hospital has to look at how much work it's doing, and it has to look at its own data. So I think that he made that point reasonably well. You're quite right. You know, how do you actually measure the outcomes in a way that actually is fair and scientific? I think it is quite difficult. But what you can do is look at an MDT over time. So are the processes in place? You know, that's the absolute benchmark. And then you have to look at volumes coming in, how much operating is happening, and then the ultimate outcomes, survival, etc., and the cancer outcomes. So I think it is something that we do need to, we need to have that mirror. And if you're not looking at your data, I think you do that at your peril. But I think you're quite right. It is quite difficult to measure, but we have gone beyond the stage of saying that MDTs are an irrelevance. They are absolutely 100% in the centre of our cancer care. And a well-functioning MDT is great. It's great for training. It's great for professional development, for all of our professional development. And I think it does help with the complexity that we're dealing with now.
I think we know inherently that an MDT is a good thing. Different MDTs can function very differently, can't they? MDT in our unit might be very different to one in the west of the country or the north of the country or wherever it may be. How do we ensure that MDTs are making the same decisions for the same patients? Because there is some MBOCAP data to suggest there's a wide variation of the application of neoadjuvant radiotherapy, for instance. So is there now a role for not only bringing clinicians in one hospital together to share ideas and get a minimum standard of treatment for their patients, but also people going from one MDT to another and sitting in another MDTs and getting some sort of consensus thinking as well?
So I think there has to be a reasonable pragmatic balance about how you and I use our time. But I think it is important to go in and almost be the independent friend, good friend to that MDT and ask some critical questions, saying, what is your data for this? Because sometimes we can work in MDT silos, so not the specialities, but each MDT might be doing something that they think is right, but without actually looking at all the available data. So I think that's important. I think we should be looking at the data of the MDTs themselves. I think that should be something between regions we should be comparing. We should be looking at the best people. So we often in medicine look at where things are going wrong, which is absolutely, you should have some focus. But the human brain works, the best and most plentiful connections are when you're doing something positive. So we should look at what we're doing well, and I think we don't do that enough. MDTs are rich mines of data, which we should look at.
Okay, sharing best practice.
Yeah.
The MDT case that we discussed, youngish lady, very early rectal cancer, very low. Radical surgery would have meant probably an APR. She had a 0.7 millimetre margin after a TEMS, I think. What do you think about a 0.7 millimetre margin in an SM2, Kikuchi SM2 cancer?
So I think we are so beholden to historical data, and we have to use that's the best evidence that we have. But to me, for that particular lady, that there were three options that she could have had. She could have radical surgery, which would have meant a huge change in her quality of life, an operation with huge morbidity. Potential radiotherapy, but that was in her particular case that there were issues there, and there would have been the watch and wait. And I think you have to again personalise the treatment. I personally think in that situation, I think the margin was sufficient, but we can't play Russian roulette with these patients. I think we need to keep gathering data. And I think you're aware of some data from Holland.
Well, there is some emerging data to suggest that perhaps cancer margins are more stage dependent than we once thought they were. So perhaps a margin of a millimetre in a very advanced rectal cancer measured at the circumferential resection margin in the mesorectum isn't the same as the same distance as a deep margin in a Kikuchi SM2, for instance. So a 0.7 millimetre margin may well be sufficient in a cancer of that stage. But we'll have to wait for more data to come in.
Yeah, absolutely. I mean, that's the fascinating thing about biology, isn't it? We're dealing with biological systems, which means that actually nothing is black and white, and you have to have hypotheses. You have to prove and disprove things. And I think it would be a brave person who said, this is the ultimate rule. There are very few things you can say, this is the rule. And I think this lady, has had a good outcome ultimately.
Great. Well, it's fascinating to talk to you once again, and thanks for coming.
Pleasure.
So we've seen some fascinating things discussed during this episode, and hopefully that will stimulate some discussion and new ideas back in your hospital as to how to improve the care that rectal cancer patients receive locally. Remember, if you'd like to get in touch with the ICENI Centre through any of the routes shown here, then please do so to give your feedback, and we look forward to welcoming you next time. Goodbye.